as a guest at Seattle Science Foundation. And we want to talk about something that's, hopefully off the beaten path for most spine surgeons on a daily basis. Maybe it's a little bit more in our beaten path for some reasons we'll talk about, but it's talking about epidural abscesses, specifically at spinal cord level. We want to talk about some of the controversies, whether there's a role for non-operative management, and sort of feel out the group in terms of some of the decisions that go into, whether or not you treat these people with surgery and kind of how you do it. And some of the more heinous things that we see in Philadelphia end up on my Instagram at things I pulled from the human spine. So I'm just going to give that a plug. All right, so we're going to talk about Philadelphia and why we love treating spinal epidural abscesses. Talk a little bit about, and this is all sort of evidentiary basis or a brief lit review. And there's not a heck of a lot out there, but talk about who gets away with antibiotics alone. One of the most important things is who gets paralyzed, although there's not real great answers. Some of the instrumentation choices, and this part is really just throwing things out there for discussion, not that there is a well-defined body of literature about this. And then we're going to jump into cases presented by our 4 fellows at Rothman Institute this year. So Philadelphia, who puts the H in Philadelphia? Kensington puts the H in Philadelphia. This is a neighborhood in kind of north part of Philadelphia, was made famous by a New York Times Magazine article a few years ago that's called Trapped by the Walmart of Heroin. And just to read the subtitle, it said, a Philadelphia neighborhood is the largest open-air narcotics market for heroin in the East Coast. Addicts come from all over and many never leave. And then this was the Philadelphia version. They put this on the bottom, except to go to Jefferson. So they do leave to come to Jefferson. This actually is a picture from outside of one of our partners, Greg Schroeder's clinic, where they're lining up to get treated. So, who really, one of the big issues here, one of the big questions is who can get away with treating with antibiotics alone? And historically, this wasn't really much of a thing, but there are a number of recent articles which touched on this. And this is not like a highly edited group of articles. This is essentially the only articles that are written on these subjects in the last 3 or 4 years. So it's not a topic that people publish on a lot. 2019, this was a group that was about half and half surgery, non-surgical. Of the non-surgical group, about a quarter of the cohort, so half of that group was readmitted for infection. And ultimately, this ends up, when the dust settles on this patient population, about 80% ultimately need an operation. And so again, is there a role for non-surgical management in this population or in this series? There wasn't a big role. Patients who had delayed surgeries, meaning went non-surgical route, failed and came back, were more likely to have MRSA, and that may be a sort of a reason they failed in the first place. But also when they came back, were more likely to have bacteremia and sepsis. So it's a little bit playing with fire, in part because of the follow through on a lot of the patient population, particularly when you're dealing with an IV drug using group. Another study from 2019, this was a sort of Italian group that looked at a treatment algorithm, and they just said it up front. Reason I had it highlighted there. Indications for surgical management are spinal epidural abscesses, period. Essentially invoking a treatment strategy where there's really no role for non-surgical management of a spinal epidural abscess. And it should be, interestingly, this is even talking about, we have much bigger tolerance for that at a non-cord level, in the lumbar spine. This doesn't really even attempt to distinguish between that. Early versus delayed surgery, again, telling you, this is a relatively recent article from 2020, doesn't really even acknowledge the fact that there is a non-surgical group, although there is in their paper. 40% early, less than 12 hours, which is, very aggressive. 38% late, 22% non-op. And the early group did better. So, they're saying that the early group does better even than surgery during the same hospitalization later than 12 hours. I mean, that's pretty admirable if they can get to every patient in 12 hours. High readmission rate in the non-surgical group, and ultimately 5% of those had surgery, 5% of the cohort had surgery out of the non-op group. So again, you're looking at this natural history number that's 80-something% of these patients, whether or not you try to not operate on them or you try to operate on all of them, if you're dropping around 100%. But even if you try to not operate on a certain percentage, a large amount of them end up having an operation. The group that in the recent years has done the most work is out of Harvard with Schwab and Harris and Nelson. There's a series of papers that are on kind of related topics. This one is on non-operative management of spinal epidural abscesses. And the one thing I'm really proud of, Akash Shah, who I've never met, but between these two papers that were 1 year apart, evidently he graduated from medical school. But this is focused on identifying risk factors for non-surgical failure. And like they have it's a decent sized population of a couple hundred. They looked at, some of these are obvious, right? Like if you have a motor deficit or sensory changes, like you're not likely to be able to be treated without surgery. Some patient-specific risk factors that lead to immunosuppression, diabetes, malignancy. And then one thing that's sort of interesting, which I'd never heard before, was compression fracture. Now, it wasn't real prevalent even in the group that failed non-surgical management, 10%. But, it's sort of an interesting take on destruction of the vertebral bodies as probably a location for harboring infection that is not well treated, or ventral location. And this may have something to do with the surgeon's willingness to sort of take a chance in the setting of an inflammatory process going on around the anterior spinal artery. And then they built a machine learning algorithm, which is available online to predict failure. And so this is, I think, the most organized approach to this. They have a number of papers towards this, and we'll see it in the next section as well, on where the rubber hits the road and, really who gets paralyzed. And this is something which I think disproportionately, and this isn't a criticism because I'm doing it still, 10 years in, but this is something which is I think disproportionately affected the way that we treat these patients at Thomas Jefferson. We have a couple cases which are burned into the collective memory of the spine group, where patients who were either known to us or unbeknownst to us and just in the hospital were being treated non-surgically for spinal epidural abscess at the spinal cord level. And, one day the intern rounds on them and they're moving everything. And the next day they're rounding on them and they're not moving their legs. And it's because they had a spinal cord infarct. And so, we're scared of that shadow, and it still affects the way we treat these patients. And just to sort of refresh everyone's memory, like this is not just about spinal cord compression. Probably that's the number one reason why patients with spinal epidural abscesses get weak, is they got a huge abscess and it pinches their spinal cord. But there is a certain percentage of them with vascular compromise, whether that's from septic emboli or whether this is an infarct from an inflammatory process which clots off an anterior spinal artery in the thoracic spine. These are the patients who suddenly do worse. And, the two cases which I was referencing before probably were both these. And a lot of times these patients don't bounce back. And we'll see that isn't necessarily the case when you're dealing with compression of the spinal cord from, an expansile lesion within a contained space. And specifically, this isn't advancing. There we go. Same group from Harvard had a paper looking at creating classification system basically for spinal cord compression. You can see this figure at the bottom. It's sort of like a little borrowed from some of the epidural tumor stuff, but it makes the concept makes sense, except that spinal cord compression was only predictive of pre-treatment deficits. So like if you're, that's not really news. If your spinal cord's pinched, you might be weak. It was interestingly in their cohort not predictive of final motor examination and not predictive of mortality. And so I'm not sure exactly what you take home from this, other than like if they're weak beforehand, you probably ought to operate on them. Certainly it doesn't give you a lot of, because I don't think this is saying that patients with really bad spinal cord compression did okay. I think what it's more saying is that there are patients who even didn't really have bad spinal cord compression who didn't do okay. And so, I think it highlights more than anything the fact we don't really know which of these patients to operate and which not to. So this is just a laundry list of potential considerations. In the setting of an anterior cerebral discectomy or corpectomy, what do you use for your graft? Whether it's just replacing the disc space or whether replacing a whole vertebral body. At Jefferson, we've been very aggressive historically at harvesting iliac crest. Obviously, that comes. It's mostly a young patient population who is not going to infect that site, but it's a sort of a pain in the ass factor. It's a time factor. It's a morbidity of, just people having chronic pain from that site. It's in a patient population that usually the opiates available in the hospital don't touch. There's a question about that we've struggled with anterior cervical plating versus, putting a piece of graft up front, no plate, flipping them, putting screws in the back to try to keep your plate away from a prevertebral pus pocket or even just a kind of in the spine pus pocket. The use of metal cages, there's decent literature that suggests that's okay. Peak cages, I think everybody is kind of down on peak cages in the setting of infection. It sure is easy. And then single stage versus two-stage instrumentation. Do you bring these people to the OR, get all the pus out you can, put it on ice, come back a couple days and put screws in, or do you do it all at one fell swoop? Because it's hard when the charge nurse won't call for your case and this person just gets kicked down the week. It becomes sort of a pain in the butt. And so without talking anymore, I want to get into the cases. The first case is a cervical case by Brian Karamian, who did a 2-year fellowship with us and is going next year to Utah. Let me unshare, sorry. I don't know how to unshare.
We got it.
Oh, you did? Okay. Oops, I just reshared it. Thank you.
All right, let me share my screen here. All right, so my name is Brian Kramer. I'm one of the fellows here at the Rothman Institute, and I'll be presenting one of our cases. So this is the case of a 34-year-old female who has a substantial history of IV drug use and polysubstance abuse. This patient was using heroin on a daily basis. She actually presented to an outside hospital 1 month prior to being seen at our facility. And at that point, she was diagnosed with C5-6 osteomyelitis. She had documented prevertebral abscess. She was bacteremic with MSSA. And unfortunately, she left AMA without any course of antibiotics. 1 month later, she popped back up at an outside institution and was subsequently transferred to our hospital. And at the time she presented, she had complaints of back pain, fevers, upper greater than lower extremity weakness. She had diffuse numbness and tingling in her upper and lower extremities. She had bowel and bladder incontinence, saddle anesthesia, and she was last able to ambulate 4 days prior to admission. Whether good or not good, she had not been able to use any heroin because she had lost function of her hands for the several days prior to presenting to our hospital. So in terms of her examination, her upper motor extremity exam demonstrates significant weakness, especially triceps distally, so her triceps wrist extension, grip, and interossei were 2s and 1s. She had relatively maintained strength in her lower extremities, 4s bilaterally. Her sensation was intact. She was hyperreflexic in her biceps, brachioradialis, and patellar reflexes. Had long track signs, positive Hoffman's, had 2 beats of clonus bilaterally, but a normal rectal exam. So I'll go on to her imaging here. So on the right, you'll see just a mid-sagittal cut. I'll play the sagittal CT. But essentially what this is demonstrating is significant destruction, vertebral body C5-6. She has an osteomyelitis, focal kyphotic deformity. Even on the CT scan, you're able to appreciate a significant prevertebral abscess. The posterior elements, although subluxated, are still intact. And I'll go on to the Sagittal T2 Mri, again, mid-sagittal cut on the right, demonstrating significant prevertebral abscess, discitis, osteomyelitis, focal kyphotic deformity, compression of the cord with some signal change. And you can appreciate that here on the axial cuts as well. All right, so before I go on to discuss what we did, let's see if there's any discussion on in terms of how we would treat this and opinions.
And I think, like, just to cut to the chase a little bit, like, I don't think anybody's walking away from this. This is not like a call ID kind of situation, but I think that the questions rolled into here are front is a given. With a 2-level corpectomy, I think probably most people are also going to go in the back. It seemed like on the T2 sagittal cuts, there's a big, whether it's a collection or whether this thing in the front is phlegmon, it's certainly an infected prevertebral space. And so the question is, like, what's the bone graft or the, support structure, and then whether you're plating this.
All right. So to go on what we did. So we did a front back procedure. In the front, we did a complete C5, C6 corpectomy. And in the front, we decided not to plate. We took iliac crest, approximately 5 centimeters, to try to restore deformity. And then we ended up backing that up posteriorly from 2 to 1.
And I'm sure that C7 screw that is in the frame is mine. I'll just take credit for that right now. And so, I mean, I guess so would anybody put a plate in the front and be done with this, up front? I mean, and again, I think that the strength of this case is not like that it's a weird one and that it was really collapsed and stuff. I think it's more about those questions that are rolled into it about generally about cervical plating in the setting of what looks like a prevertebral involvement, and whether we take crest, I think, for almost all of these, but I don't think that is necessarily something that people love doing.
I mean, I think this is a extraordinarily beautifully handled case by you guys. And again, liquid pus is one of those issues that hesitates all of us. And to the present date, the ID community is very against us using metal in the presence of an infection of liquid pus. So this is still a culture war that's, at least in our institution, unresolved. But I think that the thought of getting this cleaned up and having a biologic graft in there is inspired. And whatever that C7 screw is, I don't see a problem with that. This is a dramatically, you've achieved everything. You have a biologic construct in the front, and you have a rigid, least possible segment involving posterior construct in place. I really think that an anterior plate here might have had a small role if you had a very sick patient, you just could not handle the patient, but then you could argue just to wash it out, put an antibiotic spacer and bring the patient back later. But as such, I would almost call this the state-of-the-art practice for this kind of a situation.
So what antibiotic spacer? Tell me what do you use? What would you?
So we use PMMA with tobramycin added and vancomycin. So 1 gram, and that actually leaches out antibiotics very powerfully for somewhere between 3 weeks and 3 months. And it goes back to Seligson, who was the vice chair, I believe, in Kentucky. He actually published extensively on that. And it's the same thing that the trauma and the total joint orthopedic surgeons do if you have a very fulminant infection. It's a reasonable spacer it'll not incorporate, but it has a unparalleled local antibiotic kill rate. We've actually published on that with Wyatt Ramey, R-A-M-E-Y, and shown how safe that is. And again, it's home mixed and it stays relatively inert, and you can relatively easily remove it at a later date for a biologic graft or a graft of your choice.
So Jens, obviously these type infections are different than the more low virulent chronic infections that we've been seeing, with late explants of artificial discs in the cervical spine. But we do see anterior abscesses, but it's a lower virulent infection like a C. acnes, and we've kind of been universally treating those with basically just washing them out and using a cage and a plate just anteriorly. Now, obviously, this is a whole different game, but I think for this type of more virulent infection, for sure, this is the way to go. But
sorry, what was the interbody you're using? You said a metal cage or a PEEK cage or?
Well, the ones we've got about a half a dozen of late infections of cervical artificial discs. I think 5 out of 6 have grown C. acnes. Half of them have had actual frank pus. And yeah, we used a PEEK cage, a plate, a biologic, and it doesn't have this kind of mechanical instability, obviously. So we just did it just anteriorly. Obviously, this is,
Scott,
a whole another realm of infection.
Scott, clarify for him. It's just not a PEEK cage. It's a titanium coated PEEK.
Titanium coated PEEK. I'm sorry. Yes.
Gotcha. Maybe just a segue. Do you want to, DJ? Do you want to put your case up which is sort of a counterpoint, or from our standpoint, and see if
Yeah.
this would be something that like people would be sort of more
Yeah.
comfortable.
Absolutely. My case is very similar. You guys will see my case is very similar to Brian, so we'll kind of skip over, but the differences are that we use the plate. So this is it's a very similar case. I couldn't quite get my movie to work, but I just got some stills. This is a 45-year-old IV drug user, came in similar, presentation, unable to use her arms over the last several days, bilateral upper greater than lower extremity weakness, long track signs, fevers, positive blood culture for MSSA. Then we get the call. So this is our exam, which obviously very concerning, deteriorating, especially at 5, 6, 6, 7. She in her lower, she was around, kind of had 3s, certainly globally weak, and had some positive Hoffman and Babinski. You can see here, she was quickly sent to an MRI. So these kind of evolve differently based on who's the ED physician intake, how quickly they get to orthopedic resident, and spine fellow on call. So I get this call. She's already in the MRI due to her, they're getting MRIs before you're getting x-rays. And we see this large destructive, spondylodiscitis lesion, mostly noted at C6 in the top half of the C7 with this kyphotic deformity. It looks very similar to Brian's case, besides it's just one level down. So you can see here, right greater than left compressive. There wasn't really anything different in her exam. It was pretty symmetric bilaterally with her weakness in her upper extremity, especially past the C5, C6 level. So we elected to take her urgently to the OR that night. And we did, so you can see here, she has this large kind of prevertebral phlegmon. She also has this thyroid nodule. This isn't a part of the abscess, or this isn't an abscess here, but she has this large kind of phlegmonous anterior. Most of the compression in the cord seems to be coming from anterior and originating from this destructive disc. When we took her back, we were able to we took iliac crest and did pretty much a full corpectomy at C6. Now at C7, probably the top 50% of C7 was still in continuity. Obviously the disc, the C6, C7 disc is destroyed, but it had preferentially worked cranial instead of caudal in its destruction. So we felt we were able to really decompress the anterior part of the cord. There wasn't as much liquid back of, pus. It was more of this kind of inlet type of phlegmon material, both prevertebral and at the level of, pre-cord. Took the large iliac crest, and then, in the case we had thought that, kind of where our thoughts were: 1, we wanted to maintain alignment. 2, she was having some generalized airway difficulties that they assumed were mucus plugging, and she was scoped in the OR. And kind of the better part of valor, we thought after our decompression was done, our iliac crest was placed, that we may place a plate just in case our flip, if there was going to be any type of problem with a flip, or if we needed to kind of get the patient kick down the road a little bit to do our posterior portion. I felt pretty strongly about doing the posterior portion, only due to that large kyphotic deformity and the correction that we saw in the OR. And then sure enough, kind of as the case is unwinding, anesthesia is like, yeah, we would really love to proceed this another day if we could further investigate why she's not oxygenating as well as she could be. And so that's what we did. We'd like to put on this plate. Post-operatively, she got a lot better. And she improved very significantly in her upper and lower extremities, and was able to ambulate like 50 or 60 feet. Then we took her back a couple of days later for the C5T1 posterior construct. So, to Jens's point earlier, it's like, plating versus not plating. I think there is, there's not a lot of great literature, but, when you extrapolate kind of from the total joints literature or any of the other things we do in orthopedics, like it seems very counterintuitive to place new titanium or new non-autograft into an infected wound bed. But there are some studies that are showing, obviously small case series, that the lordosis achieved, or the correction achieved in surgery, is better maintained than autograft without any plate. The reinfection rate or return to OR is similar, and the fusion rate is much higher, probably due to the fact it's just more biomechanically advantageous. And you're not just placing autograft into like what is already destructed or unrevealed destruction in the prevertebral body. So I brought this up just to kind of piggyback on Brian's, because it is just a little different. We didn't decompress in the back. We just wanted more fixation in the back, and then just see if there was people that were plating or not plating.
I mean, and like it was fortuitous that you guys put it on, because joke probably would have been on you if this patient, you know, the anesthesia forces the bail on the posterior, because either in 2 days when you came back, you would have like had to go back in the front and either put that graft out of the spinal canal or pick it out of the back of the esophagus, or you would that night you would have had to put the patient in a halo. Like neither one's so great at 2 or 3 in the morning. This is the surefire mark at our institution of a 2 in the morning, is because no one really likes Synthes Vectra plate. You only use that one when it's like the one with the best reps, and they're going to be there no matter what time you call them.
Right, that's right.
All right, so thanks, DJ, appreciate it. Why don't we move on to, I think the next one we were going to do is Andre's case, Andre Samuel.
Yep, let me share my screen here.
And this is switching gears to a couple of thoracic cases.
Okay, you guys can see that all right?
Yep, we're good.
Okay, so yeah, my name's Andre Samuel. I'm another one of the fellows here. And this case is a slightly different flavor compared to the last 2 we just talked about. So we have a 57-year-old male who's presenting with 1 week of bilateral lower extremity weakness, decreased sensation in bilateral lower extremities, and then episodes of fecal and urinary incontinence all over the past week. His past medical history is positive for diabetes, hypertension. He's also a daily smoker. And then his history is also positive for bilateral foot INDs. So he's not really the healthiest guy here. As far as his physical exam, he does have diminished motor function in bilateral lower extremities. You see his exam here, full strength in the uppers, then lower extremities, really 2s in the iliopsoas and quads, 3s in tibant and gastroc, and 1s in the EHL. He also has diminished sensation caudal to the nipples. He's hyperreflexic in bilateral lower extremities, but he does have a normal rectal exam. So going on to his imaging now, we see on his CAT scan here, you'll see osseous destruction of the end plates and the bodies of T6 and T7, basically extending laterally to the rib heads at T7 as well. So this is pretty concerning for osteomyelitis and discitis here. But of note, he does have maintained alignment. And then if we move on to the MRI imaging. So here's his sagittal and transaxial MRIs. Here we also again see discitis and osteomyelitis at T6-7. We also see an intradiscal abscess and then a small epidural abscess just ventral to the cord. But this does cause effacement of the thecal sac and some slight deformation of the spinal cord with some very slight myelomalacia. You can see that there. This is just our full-length MRI showing no other concerning lesions within the spine. On presentation, his lab values were white count of 19, CRP of 5.9, and ESR of 65. And then his blood cultures were also positive on presentation for GPCs and chains, and this eventually speciated to Streptococcus mitis oralis. So kind of a weird bug here.
But probably grows on arms.
Yeah. So our diagnosis here is a T6-7 osteomyelitis discitis with epidural abscess, basically causing a T7 Asia C incomplete spinal cord injury. So just talking about some of the options for treatment, you could consider treating this medically. I don't think that's something that you would really is viable with the level of neurological decline here. You could talk about a full posterior decompression. You could talk about an anterior decompression, either with cage or autograft. So if you guys have any thoughts on how you guys would treat this.
Yeah, again, I think it's like less about whether this is a surgical case. I think obviously, not to say we operate on everybody, but we operate on a lot of them. But this guy's weak. And so the question is like, is that, first of all, is that straight enough that you can just do a lami? There's a little bit of posterior element buckling maybe, or probably from the collapse. Anyone? No?
This is Jens. So I think this is, you mentioned before the vagaries of epidural abscesses. And this is obviously a combination of structural disease with erosive changes and cord compression. By that MRI cut, it looks like the cord is already going into fusiform swelling, and she's mentioned probably on closer view some cord signal changes. So I think if you don't address both issues, the stability and the removal of the infectious burden, you will ask for a problem. And again, the question that I have is, and we have not sorted out internally, is I have a partner who basically does a mini costal transectomy, washes out this stuff and puts percutaneous screws in there. And I am the other extreme. I will remove necrotic bone through a little bit more expansile costal transectomy and use organ donor and bone or something like that, 2 levels above, 2 below, or titanium. So I think this is clearly a problem case, moreover, since this is in the watershed area of the cord. So any anterior spinal artery vasospasm or whatever it may be mediated by will be a catastrophe. So I fully agree with Sergey, and I think a decompression alone here would be an invitation for disaster. Thanks.
And also, I just want to say in the chat, Dr. Chapman sent the link for the antibiotic and pregnant PMMA paper, which I actually, as soon as we hang up, I'm going to look up, because we haven't really done that. I've never done that in my life, but I'd be very interested to know, because it sounds like a great temporizing measure. If anybody else has something they want to say right now, otherwise, take it away, Andre.
Okay. Okay, so as far as our treatment, it's kind of along the lines of what you talked about, Dr. Chapman. We did a laminectomy at T6 to T7, and then we did a right-sided T7 transpedicular decompression. We didn't place an anterior cage, but we took down the pedicle, got in front of it, and kind of tamped back any compressive pathology that was there ventrally, and made sure the entire ventral surface of the cord was free. We were able to really irrigate out the disc space there. And then we did think this needed structural support as well. So we did a posterior thoracic fusion T6 to T8. His oral cultures grew out the same bug, Streptococcus mitis. So he was treated with IV antibiotics, and at 2 weeks post-op, he had slightly better exams, surprisingly. So 3 out of 5 in bilateral lower extremities. So he ended up doing
which isn't like terribly encouraging. I mean, like, and so you sort of wonder with some mild cord signal changes, maybe like a little bit of almost like expansion within the compressive lesion of the cord. If this guy has a combination of the compressive lesion and maybe some cord infarct, he's not nothing, but that's not so great if this was a compressive lesion that you'd expect to sort of bounce back because it was a relatively acute onset presentation. So actually one of our partners, David K, just wrote a comment, which I've been trying to monitor the chat room and with limited success really, but is there concern about anterior column support in a case like this? Yeah, I mean, sure. I don't think, maybe it is, I'm not sure. I don't think this is my case, but like, you certainly worry about it. You worry about it less, I think, in the thoracic spine where you have a little bit of more inherent stability. Like thoracotomy isn't trivial. Certainly like this could be a in this scheme of a thoracotomy, or it's hard to, I always find it's hard to put a solid piece of graft in from the back that you feel good about, because you can't expand it in situ. You end up trying to like push the spine towards the side you're putting in, kind of accordion it open and jam as big a piece you can without hitting the spinal cord and hope it works. You think about doing it a lateral. So if it was me, I don't think a thoracotomy is totally trivial, but it may help this from collapsing, especially in a patient population that may not follow through on their full course of IV antibiotics.
I would say, Chris, it's interesting. As I think about it, we do far fewer transthoracic things than we used to. I think that we do much more anterior column from the back. But
yeah,
yes, I not so many these infections as I think. You do more than I, but I think that's the case.
No, I mean that's true, and like that. I'm not sure that that's a good thing. It certainly is a convenient thing. And that's, I think somewhat we've been like overwhelmed in some ways in Philadelphia by, the opioid epidemic. And we've been overwhelmed by the closure of the other hospital that actually, took care of people that were uninsured in Philadelphia. And you get a ton of these, and like, it's a lot harder to find 2 OR slots and a general surgeon to do a thoracotomy, because we don't do it ourselves, because that takes hours and hours and hours. And like, maybe that's a mistake. I think that we're in the midst of it, not to say we're just figuring it out, we're just seeing what happens. We're in the midst of kind of collecting these patients in a prospective manner to see, like, are we doing okay? And if we're not doing okay, when that, those numbers mature a little bit, then we're going to have to go back to what I agree, what we used to do when I was a fellow, which is like everything was a front back. All right, let's, most of the question is from the front. The instability is not that great. So someone else wrote in response, I think David K's comment, could we have just done an anterolateral decompression, preserving the lamina? Like 100%. That's a decompression from the front, taking down the rib head, taking down the pedicle, either whether it's a piece of autograft or a piece of allograft in the front for structural support after you take the majority of the posterior aspect of the body and get around the equator of the cord to the contralateral side, definitely an option. And I think that, that surgery is often overtreated with screws from the back, because you really haven't done a hell of a lot to disrupt the stability of the spine, provided it's a thoracic level surgery. So, I think that's is definitely an option. It's technically harder, but maybe at the end of the day, that's a better option, because you don't have a bunch of screws into infected bone. So I'm not against that at all. It's something we've sort of gotten away from because of the thoracotomy and the dependence on general surgery. But I think that's a good option. All right, so let's move on to the other. Do you have anything else, Andre, or is that the end?
No, that was it.
All right, so let's go. Chelsea Hendow is our 4th fellow this year. She has another thoracic case.
And you're muted, Chelsea.
Thank you. All right, see if I can go back. So I am presenting another thoracic case. This was a 64-year-old man who presented with isolated back pain. He, on questioning, had some associated night sweats. Maybe it started around the time he fell a couple weeks ago, but no major red flag symptoms, no bowel or bladder incontinence or symptoms of myelopathy. He does have a history of squamous cell carcinoma. He was treated with chemotherapy. He has a port in place. He had extensive radiation to his head and neck. And he also looks like he has an infection in his toe when he presented, but is otherwise neuro intact. And just the labs, highlight an inflammatory process, but not necessarily pointing firmly in an infectious direction until his blood cultures came back as MSSA positive. This is his thoracic MRI, which demonstrates a dorsal epidural abscess without significant cord compression, but sizable. This is extending from T6 to about T9. I think the question with this case is less which surgery you would do as our last few cases, and more, is this the case that you could treat non-operatively? So I guess I would open it up and see if anybody has a vote one way or the other.
Because we don't treat everything, even despite the AVDT, which you've never heard of. It is the Alex Vaquero decision tree. that doesn't have branches. We don't treat everything with surgery.
Hey, so one thing that we've always looked at is the albumin level, a very coarse screening tool just to look at the general catabolic or anabolic state of a patient. So what would that have been in this patient? Is that above 3.2 milligrams per deciliter, or is that something that you guys use in general?
You're embarrassing me. No, no, I don't. We don't think to get that. That is, and so I flesh that out with me a little bit. Like, so the idea behind that is that like that's a measure of the patient's overall general medical health.
It's a general, very vague. It's like a sedimentation rate for nutrition. For instance, general complications like infections happen way higher in our Washington State database in patients who have below 3.2. Against the screening test, it's very variable, highly dependent upon other metabolic conditions, liver disease, etc. But for these infection patients, the unproven hypothesis, which we're looking at as one of our variables, is that patients who have 3.2 or higher will be able to synthesize far rapidly an immune response, whereas those who are below that have a far greater struggle, and especially those below 3.0 are in a real crisis situation. So they're doing like a damage control, debridement, some stabilization, and coming back on another day because they may have a hard time healing. At that state seems more sensible. So it's a more physiologic, nutrition-based kind of an approach to try to pay credence to the patient's general wellness.
It's like somebody who's sleeping in a tent in Kensington may not have like a real high albumin. So that is something that we don't do. That's great to hear because we certainly, you know, that's not a sophisticated send out lab. I mean, we should be able to get that. So I appreciate the comment. I don't think we probably have that answer.
Chelsea, in this case, I just was looking, and when you look at the MRI, is there a specific disc space that you think that this has arisen from? Because I didn't see it when I looked at that MRI on your.
It's dorsal. It's dorsal, right?
I mean, it's all dorsal. So I'm wondering if it comes
Yeah.
from this space or is simply
Or a facet joint, maybe, but
yeah.
Yeah, there are a couple facets that showed some enhancement. And actually, the radiologist on reading this wasn't sure, couldn't definitively say whether this was hematoma, infection, or carcinomatosis because the T1 post-contrast images were motion degraded. So, and that they're difficult to tell apart to start with. So those are all factors sort of muddying the picture a little bit.
all right, so show the AVSDT.
And we did a laminectomy. So we did a laminectomy of T7 to 10, basically just following the gross purulence that was found up and down until no further purulence was found.
And like, I think the whole question is like, do we need to do this? I'm not really sure the answer is out there. The most depressing thing I saw in kind of preparing for this was trying to do a lit review on who gets paralyzed and who doesn't, and seeing that study from Harvard that was kind of like, well, we don't know, which I think was the take home point. And like, again, like that wasn't like a prospective 1,000 patient study, but like that doesn't really exist, in the real world, except for at Dartmouth. And, that was as good an answer I think as you're going to get about it. And the take home was like, patients who didn't have spinal cord compression did as good as patients who do have spinal cord compression. And I think we're still being at Jefferson, and some of this is a little bit before my time, and certainly it's not before. I mean, certainly that sounds negative. Is Alan was here during that time, and we're still a little bit running away from our shadows of a couple really notable patients with spinal cord abscesses or spinal abscesses at cord level that like turned out really bad from non-surgical management.
I agree. That really is, that was always the discussion, every single discussion for 10 years. I mean, like 10 years, I think before you even came as a fellow, 12 years ago, Chris, we had that discussion. They can have a spinal cord, anterior spinal artery infarct. they can be paralyzed. They won't get better. That's a bad, and like Chris said, I mean, it's a bad situation because they don't usually recover.
Right.
And we've only had a couple. I mean, I know the ones you're talking about. I don't think there's anyone besides those two, but they're bad.
I mean, I had one. I had one that happened as an additional kick in the teeth. A big abscess dorsally, small abscess ventrally. Went in the back on a Monday. Did a laminectomy. Got a bunch of liquid pus. Felt like we were heroes doing God's work, et cetera, et cetera. He's probably a Catholic priest. And then on Tuesday, between the planned posterior and anterior stage surgeries, he became a paraplegic. And it's oh my God, that one burns, who knows, that's kind of the scary thing. It's not that bad things don't happen in spine surgery, right? Because bad things happen in spine surgery. And when you have a risky situation, bad things happen in spine surgery. I think the thing that has really given us the sort of the uncertainty in this situation is that it seems really hard to predict when the bad thing happens. And so our knee-jerk reaction has been to sort of knowingly overtreat everybody to avoid, a few bad outcomes. And so I think we've really as a group, have sort of struggled with this situation. And then insult to injury is that we are in one of the, country's epicenters for heroin use. And so we see a ton of it in high risk individuals who are young and medically healthy, except for they just have they have an addiction. And so it kind of raises the stakes. The 35-year-old guy who, if he could get clean, would be a normal person, compared to the 85-year-old guy who's on dialysis and a diabetic, and you can't sort of save him from his medical comorbidities. And so I think that's where this has been driven home, is you see people who are no matter, if you're 65 or if you're 25, you see people in your age range who ought to be healthier than they are, who are, in a bad way with this disease.
Did that case push you to treat a smaller ventral epidural abscess before a larger dorsal epidural abscess in a patient, or not really?
I think we're more. I personally, I'm more nervous about ventral stuff because there's not gonna. I always, at least you tell yourself, and there's not good data in this, but you tell yourself there's not going to be a vascular problem with a dorsal epidural abscess.
We did have a post-op albumin on this patient, and he's very malnourished. It was 2.4.
There you go. Dr. Chapman wins again.
And he had some dysphagia from his head and neck cancer, so I'm sure it's contributing.
I'm just looking to see if there's anything on the chat talk and the chat function that is useful. So, Dr. Chapman, anything besides albumin that you do as part of the nutritional labs, or is that the main thing?
We had a program at Harborview, and basically all the others are way too expensive, take too long, and therefore are irrelevant. So this is the cheapest by far, and it's crude. Again, it's multifactorial. But that was a big predictor for us in terms of the basic decision-making is this a catabolic or is this an anabolic patient? If they're catabolic, again, the basic thought for us has always been damage control, get rid of the infectious burden, the bleed into vascular tissue, stabilize and get out, and revisit fusion and reconstruction when the patient has recovered 3 weeks to 6 weeks later. And if they're in reasonably good shape in general and have not just diminished too much, then a primary reconstruction, as you've shown in several of those cases, like that absolutely gorgeous first case, are very feasible.
All right. Well, I think that, aside from the onslaught of the never-ending crush of intravenous drug users who have infections in their spine, I think we'll wrap it up. For all the Philadelphia hospitals, send the homeless, tempest-tossed IV drug users to us. We'll lift our knife behind the golden light, to quote the Lady of Liberty. It seems like it keeps happening.
No, I mean, this I'm so grateful to you and your group, and hi, Alan, also, to have chosen this topic, because again, I think this is not just in Philadelphia, it's Seattle. I mean, I could take my camera 2 streets down from here and I could show very similar pictures. It's really become a major scourge. And again, who would have thought that as we are learning about spondylolisthesis and scoliosis things and trauma fracture classifications, that one day epidural abscesses and discitis osteomyelitis would be such a major threatening issue for our case care. So that's a really big deal, and very, very appreciative. And I think everybody in the audience was, with you having selected this otherwise thankless topic. And
that's one of the problems, is not only thankless, but also it's a difficult patient population because, it's largely uninsured. And one of the cornerstones of treatments of these patients is not just like in some ways the operation is the easy part. Like that's the reliable part of the treatment. But then the unreliable part is whether they can get a pick and go to a rehab, or whether they can get a pick at all, or whether they can follow through on IV antibiotics, whether it's oral or whether it's IV, or whether they can even get oral antibiotics. And so there's all these sort of barriers to treatments of these patients that make them, unfortunately, sort of frequent travelers, even sometimes after an operation. So, it's like, it's not just a, medical or a surgical problem. It rolls very heavily into the social problems that got these people here in the first place. So
how is that with you? Because our infectious disease people who are fantastic in our facilities here, they want still the 6 weeks of IV antibiotics, which, by the way, on an evidence base are not really validated. Yeah. But they want their 6 weeks of IV antibiotics and a normalization of, they mainly go by CRP now, not even sed rate anymore. But with the COVID crisis, basically, we are now stuck with these patients for 6 weeks in a hospital. And our system used to have kind of a hospital, and that too went away. So we have a full house with 6 week dwellers.
So number one, a lot of the patients don't make it 6 weeks before they sign out AMA, because like hospital's not fun. When people are insured, usually there's a couple of rehabs that will take even intravenous drug users as inpatient. A couple of rehabs, they'll take them as inpatients to complete the antibiotic course. And so they usually go to that. It's pretty rare that we have someone stick it out for the full 6 weeks. Our infectious disease also usually will push for a full year. If there's metal in their body in association with the infection, they'll also push for a full year of oral suppression in addition to the 6 weeks. And so, I think it's a relatively aggressive infectious disease group, which probably like keeps us in check. Sometimes, like there's probably like a once every other month fight with them, but like they're usually more right than we are.
Chris, it begs the question that here you have a very unreliable population, and you're hoping that they get all their antibiotics. Had any thought to using some type of antibiotic-eluting pellets that,
that's what I was asking Dr. Chapman for his link before, and I saw he sent it twice, so I appreciate that. I think that would be a huge level of interest for that, because like that potentially could extend your grasp on these people way beyond, maybe their reliability in being available for treatment. But guess what? Like if you're back to the old shenanigans and you got something inside your body that's doing the trick despite your unwillingness to participate in your own care, like that could be something that just keeps you out of the ER the next time. Like all the evidence is that bouncing back from failing a primary treatment is bad. That's the one thing that comes through in the literature, whether it's a non-surgical treatment or a failure of antibiotics, is that the next time you come back, it's worse than the first time you came in. And, if there's any way to mitigate that would be to everyone's advantage, not just the patients, but ours as well, because sometimes you end up with a problem you don't know if you can fix.
And Chris, what percent of your patients that are drug abusers that got their infection from drug abuse actually come back for follow-up? Or do you think they all go back in the streets again and they're back in the same?
15 or 20. Alan, what do you think?
Yeah, I think that a lot of patients come back at 3 months. And after that,
like back to the ER, just to be clear.
Oh, no, but actually I was going to comment, someone had a chat about, the incidence of like wound complications. I actually don't see that very often with these patients. Maybe it's because they're on big time antibiotics. But usually, these, even if they're bad protoplasm and they have a low albumin, I think they still do pretty well in terms of not getting infections.
Not getting wound infections. Yeah, I mean, it's a young patient
wound
population.
infections, right.
They should have an immune system.
Yeah, that was in the chat right now. We've had the same experience. Their wound infection rates are actually not an issue. Even in non-compliant patients, they actually heal surprisingly well, and that's really not a big deal. And with Harvard, we published many years ago using structured allografts using an ingenious tracking system. So our follow-up rate was great because we have free methadone in our city. We can outdo Philadelphia. Free methadone, come to Seattle. Free needles, of course. I'm not joking. We have free methadone here. So you have to sign up for a clinic, but we tracked our drug users who we then put into a methadone program. And we found that actually the few that had a reinfection later had different organisms. And we did that with PCRs. And the first author was Jim Schuster. And again, credit to him for having, he's in Pennsylvania, also in Philly, for having identified this tracking system. So they actually, when they get secondary infections, they're from different organisms, from different injections, not from the primary organism.
Jens, is that another infection? Is that repeat? Do you think that's just, people are
they can just, like in the primary situation, get a secondary infection anywhere where there's a weak spot. So Jim Schuster's study, I can try to pull that up, really very conclusively showed that the primary infection, once that is healed, is not an issue anymore. It's not a focus for reinfection. It's usually different motion or movement motion segments that then seed and gets colonized. But the primary infection is, once properly dealt with, amazingly resilient and actually very amenable towards healing once that initial inflammation has been turned around into osteogenesis.
Well, thanks everybody. I think we are just at about the 9 o'clock limit. Appreciate everybody's comments. People tune